Hi, my name is Jessica Jacobs, and I'm going to give you a brief overview of the Stage 1 meaningful use requirements. What's the backstory on this? Well, it all started with ARA. ARA is the American Reinvestment and Recovery Act. As a part of ARA, the Health Information Technology for Economic and Clinical Health Act allocated $20 to $27 billion for the implementation and meaningful use of electronic health records. In this, we see that money really does talk. Indeed, in August of 2010, HIMSS did a survey of 126 providers. This survey found that the incentive potential was evaluated by 76% of these survey respondents, and that the penalties were also evaluated by 35%. So what this shows is that people are thinking about ARA and high tech and what it means to them. So why meaningful use? Well, ARA handed out money, but it did so with some caveats. And what these caveats were that providers use a certified EHR in a meaningful manner to exchange health information, improve the quality of healthcare, as well as report and submit clinical quality measures. There are 5 pillars to meaningful use. These include privacy and security, the improvement of population health, safety and quality, as well as patient engagement, the engagement of their families, and coordinating care across the healthcare continuum. The basic timeline of ARA and high tech, as well as meaningful use, began in 2009. So high tech and ARA became law in 2009. The notice of proposed rulemaking went on display in December of 2009. It was published in January of 2010. The comment period closed in March. 2,000 comments were received. These comments were responded to, as well as the notice of proposed rulemaking modified, and by July, a final rule had been published. In 2011, incentive payments will start in May. Before this, you have to register as a meaningful user or your intent to meaningful use electronic health records, and you have to attest that you have used them meaningfully for a period of 90 days. In subsequent years, you have to be a meaningful user for the entire year. In 2015, penalties will begin. 2016 is the last year for a Medicare provider to receive payments, and 2021 is the last year for a Medicaid provider to receive payments. There are 2 programs. There is the Medicare and the Medicaid program. Different people qualify for different programs. Medicare providers are mostly ambulatory physicians, doctors of optometry, chiropractors, as well as 2 kinds of hospitals, acute care and critical access. Medicaid providers is a little bit of a wider net. These include nurse practitioners, midwives, dentists, as well as children's hospitals. The primary reason for this difference is Medicare covers mostly an elderly population, whereas Medicaid covers people of all ages. Hence, there are different types of providers that can be Medicaid providers. Medicaid offers a significant amount of money more than the Medicare program. As such, there are more requirements and minimum thresholds that must be met to be a Medicaid eligible provider. The incentive payments do differ. Ambulatory incentive payments for Medicare providers are $44,000 per physician, with a bonus of $4,400 for eligible providers in health provider shortage areas. Medicaid providers can receive $63,750 per physician. You can switch between programs, but you can only do it once. Here's a chart of the Medicare eligible provider incentive payments. As you can see, if you start being a meaningful user in 2013 or beyond, you're going to receive less money. The same thing goes for the added bonuses for being a health provider in a shortage area. Here's the Medicaid incentive structure. As you can see, you do receive the same amount of money across all of the years, regardless of when you became a meaningful user. The hospital incentive structure is a little bit different. There's a $2 million base plus an additional variable based on discharges for Medicare and Medicaid shares. The timeline on this is that for Medicare, there will be no payments after 2016, and penalties will start in 2015. In Medicaid, you can't initiate payments after 2016. Here, all Medicare hospitals are Medicaid hospitals. Additionally, hospitals which are eligible for Medicare dollars are also may be eligible for Medicaid dollars. So, are you legal? Do you have a certified EHR? ONC, the Office of the National Coordinator, issued temporary certification program, which is set to expire in December of 2011. It's handled by external bodies. The first certifying agencies were released at the end of August. An additional one was released the second week of September. These 3 certification agencies have released approximately 30 EHR products, which are certified as being meaningful use ready. This list was published on October 1st. There is expected to be a significant number of vendors certified as EHR products. If you look at this survey, the same one from HIMSS, you'll see that 75% of providers who have an EHR, their vendor has confirmed that they're going to go for certification. So that represents a large portion of the EHR market. So what do you have to do to be a meaningful user? We've talked about the technical requirements, but what do you have to do objectively? What do you have to report on? What do you have to measure? So there are 15 core objectives for ambulatory providers, 14 for hospitals. All of the hospital requirements overlap with the ambulatory ones. The only addition to the ambulatory provider list is e-prescribing. Again, ambulatory providers are those who provide no more than 90% of their services in a hospital. So most measures here have to be reported on as structured data, not as text. So the core objectives, that is the things you have to do, include maintaining and recording, doing and implementing, and providing and reporting on certain measures. Additionally, there is a menu set. You have to pick 5 menu objectives. One of these menu objectives has to do with public health. Here you see that the providing and reporting list is significantly longer than the other 2 for possibilities that are menu sets. That's because of this public health requirement. Indeed, most of the public health requirements are providing or reporting measures. Clinical quality measures were mostly selected from the PQRI initiative. This is a CMS initiative that they would like to roll up into meaningful use so that it becomes the same kind of a program. Additionally, they envision a single reporting infrastructure for electronic submission in the future so that you don't have redundant or duplicative reporting. Additionally, high-tech required that when the clinical reporting measures were selected, CMS give preference to those that were endorsed by National Quality Forum. NQF is a nonprofit, and they select and develop clinical quality measures in an iterative process. In the final rule, all of the measures were endorsed by the National Quality Foundation, the National Quality Forum. The number of measures that you have to pick is, if you're an eligible provider, you have 3 core measures and 3 that you get to pick. If your practice doesn't have the 3 core to report on, you would have this in instances where, such as pediatricians, who they don't have adult weight screens, so obviously they can't measure adult weight. There are alternate measures that they can report on that will count as their core measures. For hospitals, there are 15 measures and all of them are required. Here you see that prevention, all of the things in the core set are definitely preventative type measures, as well as the alternate set, still preventative. Things that are in the set that you can pick up from include measures that refer to diabetes, cardiology, cancer, OBGYN, psychology, respiratory, and other conditions. Hospital CQM requirements mainly have to do with stroke, patient throughput, and surgery. So what was the point of all of this? The point of all of this was that there is a difference between the 2 programs. The Medicare program is administered on the state level, with Medicaid being by state. There is not necessarily going to be a program in every state. You have to initiate things sooner in Medicare. There's less of an incentive period, less dollars spent as incentives. There will be penalties, whereas with Medicaid there will not necessarily be penalties. As I said, it is on the state basis. In the first year for Medicare, you only have to demonstrate for 90 days, whereas with Medicaid, you just have to intend to adopt, implement, or upgrade an EHR system, so the ramp up is a little bit slower. There is no rule variance for Medicaid, for Medicare. It is uniform across the United States, whereas Medicaid is a little bit more state specific. And again, the Medicaid providers is a wider net. 80% of patient records, certified EHR, 15 core and 5 menu, 3 core and 3 alternate CQM is a meaningful user for an eligible provider. Whereas with hospitals, 80% of records, in a certified EHR, 14 core and 5 menu, and 15 clinical quality measures are what is required to be a meaningful user for hospitals. Here we see that providers that are planning to pursue meaningful use is about 77%, whereas providers who will achieve meaningful use is going to be probably about 72% of the people surveyed. So that shows that 72% of people will receive the maximum benefit if they are able to achieve. And then finally, I just want you to realize that this is only the first step of 3 stages. Stage 2 and Stage 3 will be coming out in a few years, and they will have more stringent requirements. Adjustments to Stage 1 are being made by CMS. And then finally, the use of electronic health records will hopefully lead to better clinical outcomes for patients, less fraud, waste, and abuse, a better ROI for hospitals and providers, help reduce health disparities, and engage patients and family, which is the most important measure. I thank you for your time, and I hope this has helped you understand the first stage of meaningful use.